Respected Chairperson, August Gathering, Assalamu alaikum, welcoming you all to my presentation. It's a case presentation after state of art lectures. Uh, this is the story of a patient battle against calcium. So, brief about my patients. Mr. SK, 72 years old, presented to us with E4 angina, CCS class 2 for 6 months. He had a history of CABG, uh, Lima to LED, venous graft to OM and PDA. Relook CG was done in 2015, which revealed native TBD with only patent graft Lima to LED. And at the time, PCA2 distal RCA done in the same setting. So, risk factor his diabetes, hypertension, and ex-smoker. Echocardiography showing basal and mid-infra wall hypokinesia with ejection fraction 50%. And lab parameter was normal. ECG showing lateral ischemia. So we proceed for angiography, which revealed there is a distal left main disease with proximal LED 99% calcified lesion in the proximal part and CTO from mid segment. L6 totally occluded from proximal segment. OM also diffusely diseased. And RCA is heavily calcified with patent stent in distal RCA. 40 to 50% lesion in proximal PLB and 95% lesion in the PDA. So, and Lima to LED graft was patent. So, diagnosis is native TBD with graft vessel disease with patent stent in the distal RCA. So, our plan was PCI to RCA. And access, we went through right femoral and took 7 French GR. First, we wired with BMW and tried to negotiate IVAS catheter, but it is not crossed. Then we pre-dilated with 2 or 15 NC balloon, and body were taken and pre-dilated again with 2.5 NC balloon. Again, IVAS is not crossing. So we took smaller balloon, 2.58, and inflated at high pressure. Still, IVAS is not crossed. So we took cutting balloon. Initially, cutting balloon was not crossed, so we took the help of Guidezilla, and ultimately crossed. You see, there is a dog bone effect. So, angiographically, there is no significant plaque modification. What should be the what should we do next? As this is a balloon crossable and IVAS uncrossable lesion, there is dog bone effect on cutting balloon inflation. So we plan for rota ablation, and we took rota bar 1.5, and you see there is a stacking in the calcium in the proximal part of RCA, and finally ablated. Now the angiographically some modification is there. So again pre-dilated 2.5, 15 balloon and smaller balloon, and we did IVAS after rota ablation. You see there is calcium, thick superficial calcium, and there is cracking, and you see there is cracking of calcium, and you see there is crack. And we deployed drug-eluting stent integrity 3038 in the mid to distal RCA first. Then we took again 3038 stent in the for proximal. and post dilated with 3 and 3.5 balloon. And final IVAS. Stent well expanded, nicely placed, and there was no malposition and good luminal gain. MSA is 5.2 and 5.1. So this is the final result. So take home message: post CVG patient with heavily calcified lesion is not a barrier for successful PCI. Appropriate planning, availability of hardware, follow-up stepwise technique to deal with heavy calcium may overcome the obstacles. Suitable guide catheter, guide zilla extension catheter has extensive support in negotiation of wire, IVAS catheter, crossing balloon, and smooth delivery of stent. Plan, patience, and perseverance is essential tool for successful CTO calcified lesion. Thank you. And I would like to acknowledge my mentor, Dr. Mominuzzaman sir, giving me the opportunity to present this case.